I'm Dr. Bill Neal. I'm a professor of pediatrics at West Virginia University, and my specialty is pediatric cardiology. It's called the Cardiac Project, which stands for Coronary Artery Risk Detection in Appalachian Communities. It's a school-based program designed to raise awareness of cardiovascular disease risk factors. It has three components: a comprehensive screening program, particularly dedicated to fifth grade children, an intervention component, which is funded by foundation support, and a research component, which is funded by NIH, CDC, and Robert Wood Johnson Foundation. Well, this was a large retrospective study of a little over 20,000 children. We've now screened 65,000 children comprehensively, which would include lipid profiles as well as their blood pressure and other risk factors for heart disease. But this particular study looked at 22,000 children retrospectively, going back to look at the history, family history of heart disease within the families, to see which children would meet criteria for selective screening guidelines, so the national guidelines, versus those who would not, and then to see whether or not the selective screening guidelines accurately predicted those who would be at high risk. And the fact is, it didn't. It would have missed a little over 1/3 of the children who have significant elevations in LDL cholesterol, high enough to warrant at least consideration of cholesterol-lowering medication. The National Cholesterol Education Program and the American Academy of Pediatrics guidelines are that children should be screened if there is a positive family history of premature heart disease, which they define as documented coronary artery disease in a parent or grandparent prior to 55 years of age, or known elevated cholesterol in a parent greater than 240 milligrams, or other risk factors for heart disease such as hypertension, severe obesity, and so forth. It's a good question. So a very small percentage of children, 1.5% approximately, will have genetic dyslipidemia, which is a result of their metabolism, which they inherited from their parents or grandparents. And this is irrespective, oftentimes, of body habitus. It doesn't have a whole lot to do with obesity per se. It is how we metabolize fatty substances. So this very small percentage of children, when you do a mass screening program of this nature, will pick up the small percentage of children who inherited the tendency to early coronary artery disease. And there oftentimes the family history is known, and that is predictive, but in this particular situation where we retrospectively applied the guidelines, 1.7% did not meet those guidelines. That perhaps is due to the fact that the parents or grandparents may be too young to have had a coronary event, even though maybe they are indeed at risk. Well, there was an excellent paper published in Circulation, the journal Circulation, in 2002, performed by some European investigators that did a randomized, double-blind, placebo-controlled trial of statins versus placebo in children who had familial hypercholesterolemia, who therefore met the guidelines for treatment. And they measured over a period of 3 years and in a serial fashion intimal medial thickness of the carotid arteries, which can be looked upon as a surrogate for the process of atherosclerosis. And at the end of 3 years, they showed that those children who received a placebo had ongoing thickening of the intima of the carotid arteries, whereas those that were on statins did not have progression of the thickening itself. They also showed that the safety of the medication, of the statin medication, was also quite good. In this case, it was simvastatin, but there were no adverse events related to the medication. Well, there are two side effects that are carefully watched for. The most severe is, but quite rare, but nevertheless, a breakdown in muscle tissue, skeletal muscle tissue, which if it's allowed to proceed and one were to take the medicine under those circumstances, and you wouldn't because it's quite painful, but in any case, that breakdown of muscle tissue can lead to kidney failure. So folks who are on statins are advised that if you have severe muscle aches, you should stop the medicine immediately and see your doctor. The other side effect we watch for is liver enzyme rise. And so generally, just about every time on serial measurements of cholesterol levels periodically to see what the benefit has been, we also measure liver enzymes. The adult cardiologist will often let them go to 2 to 3 times normal before backing off because they found that over time it doesn't seem to cause any permanent damage. In children, we rarely have seen this. I've maybe had 1 or 2 children that had liver enzymes sufficiently high to cause me to get some other tests to make sure they didn't have hepatitis or something of that nature. But those are the 2 side effects we watch for. Yes, again, I think a good question and a good concern. First of all, we never just start treating a child, even if they have severely elevated cholesterol, on a first visit. We wait at least 3 to 6 months with attempted aggressive lifestyle modification to see what the impact of diet and more physical activity will be in lowering cholesterol in these children. So this also, one would never treat obesity per se with a statin. In fact, our studies show that most of the children, or many of the children that we identify who do reach these elevated criteria for consideration are thin, otherwise healthy-appearing children that are non-obese. The impact of obesity, when we look at it, when you go from overweight status to obesity to morbid obesity, we do not see progressive rise in the LDL cholesterol levels. About 10 to 12% have mildly elevated LDL cholesterol, but far from reaching a sufficiently elevated point to consider cholesterol-lowering medication. So I think that the lifestyle modification is always the way that one would address obesity, and these medications, for all practical purposes, are of no use in that situation. So no, we've never had support from the pharmaceutical industry, nor have I ever personally been on their speaker list or received any remuneration from pharmaceutical companies. So I have no vested interest one way or the other. But one of the reasons why I don't really think that that this study is going to lead to overuse of the medication is that there are 2 reasons. One, the market is still quite small. I mean, we're talking about a little over 1% of children, and I can't see the pharmaceutical companies aggressively marketing that on television because it's so small. Secondly, we've just learned from experience, primary care practitioners are very reluctant to use this medication on children at all, simply because they don't see enough cases. In any given family practice, they may or may not have 1 child who may meet the criteria. So they virtually always seem to refer them to children's specialized lipid clinics, which we conduct around the state. And I think everybody is more comfortable with that situation because it's multidisciplinary and we have more resources and experience to help these families deal with this problem.